metabolic rate in the children, the drug doses are usually calculated in the higher dose as per the birth of the body weight. But as far as the obese children are concerned, the obese kids have got very low metabolic rate. So even if the child is say around 80 kgs, we have to calculate the dose according to the basis of their ideal body weight. Usually, the calculation of doses we do on the basis of milligram per kilogram or on the basis of surface area. But for the convenience part, we do on the basis of body weight, that is milligram per kilogram. And where this picture comes of, say, the importance of underdosing and overdosing. As we see that paracetamol, if given half tablet to 45 kgs, it would be a case of underdosing. Therefore, we should know how much dose to be given and in how much concentration. Also, the important part of drug dosing is that the fixed drug combinations should be avoided. It should be avoided because of the incorrect dosing and the higher toxicity it can give rise to. For example, if there is, say, cough, cold and fever, and if there is a combination of paracetamol and antihistamine, the antihistamine has got lesser half-life. The paracetamol has got a different half-life. Therefore, we cannot give the fixed drug combination. Going back to our second MBBS and a little bit of learning with pharmacology, we study how the drug movements occur within the body. That is the pharmacokinetics. And the simple mnemonic of DADME occurs in pharmacokinetics. And what is that? The first is the dose which is taken or the amount of drug which is taken. And from that, how the absorption occurs at the site of the delivery into the blood circulation. And then there is a distribution of that particular drug to the various fluid components and tissues of the body. The metabolization occurs in the liver. And finally, the drug is eliminated in urine, but some part of the drug is, say, excreted in bile, sweat, tears, feces, and breast milk. From pharmacokinetics, there is something called pharmacodynamics, which deals with the biological effect of drugs in various therapeutic targets. And the most important part, how we decide on dosing intervals, is the half-life. So every drug has got its half-life, and that is how we decide how to, give drugs frequently. So there are different types of route of administration of drug, and we'll see what are the advantages and disadvantages. The most common route in pediatric population we give at home basis is oral. And the oral medications has got its own advantages, but in pediatric population, it's difficult too, because we have to see the mood of the child, the taste of the medicine matters, the color of the medicine matters, the time also matters. Therefore, though it is convenient, economical, and safe, we have to take these pictures into consideration also. The disadvantages of oral medication is that absorption is extremely variable. Therefore, one should decide when the medicine is to be given. If the bitter medicine is given after, say, food, most often the kids vomit. The medicine ideally should be given between 2 meals. Again, some medication should be given before food too. So the plenty of factors occurs, and therefore the absorption is variable. The topical medications has got its very good advantages, as there are no systemic side effects except for the, say, high potent steroid creams which we give. There is a direct action, but the disadvantages is extremely expensive. A 5 gram of mupirocin costs, say, around $120. The parenteral medication has got its immediate effect, but the disadvantage is mildly expensive, and self and ambulatory medications not possible. So therefore, a patient or the person has to get hospitalized or go in a daycare center. And inhalational medicine, as far we given as far as nebulization is concerned, or metered dose inhaler, or say we give nasal inhalation, the advantages are the quick absorption. So when we give a drug, there are adverse effects, and there are adverse effects of different types. Now, the first common adverse effect is the overdose, where there is excessive intake And if the dose, even if it is proper, it could be due to excessive accumulation because of, say, renal pathologies or liver pathologies. Intolerance may occur due to low threshold to normal pharmacological action, and there are variable, undesirable, or unavoidable side effects as seen in plenty of medications. Like we see sedation occur because of hydroxyzine. We see, say, diarrhea because of plenty of antibiotics. There are secondary effects because of prolonged use of medicines. So prolonged use of antibiotic can give rise to, say, glossitis. Prolonged use of NSAIDs can give rise to peptic ulcers. Also very commonly seen is idiosyncratic reactions given to a G6PD deficient when primaquine is used as a radical cure for Vivax malaria. And we see anaphylaxis, urticaria, commonly due to plenty of medicines, commonly antibiotic, the NSAIDs. Serum sickness is seen because of antibiotics, and GI intolerance, as we have already seen, can occur because of, say, for example, amoxicillin. The truck fever is also an extremely important adverse effect, and this occurs because of persistent use of medications. And my colleague would be taking the lecture on fever. He would be talking one of the commonest cause of pyrexia of unknown origin. And what is this ODBD? We talk with our say residents, our doctor colleagues, इसको OD दे दो, उसको BD दे दो. But these are the Latin terminology. And as you can see on the slides, it's omni-indi, bis-indi. But in practice, we should not write OD, BD, QID, TDS on our prescriptions. Write in the language the patient would understand, and it would be easier for a patient to take the medicine. We take the final treatment, take the recipe, and we jump on to the commonest medications we give in day-to-day practice on our outpatient department. We come to the cough syrups. Now, the cough syrups are plenty of types. You can see in India, we have umpteen number of formulations. In Western world, they only use hardly glycerol, as we'll see later. So there are how to decide the doses of cough syrups. There are combinations of bronchodilators and mucolytics. There are combinations of bronchodilators, mucolytics, and expectorants. There are plain bronchodilators available. There are combination of decongestant and antihistamines. There are combination of decongestants and suppressants. There are combination of suppressants and antihistamine. There are combination of antihistamine and mucolytics. There are combination of suppressants and expectorant given together. So weird combinations are available. But how to decide the doses? Whenever, especially in pediatric population, the cough is usually congestive, and we our first choice is to give a bronchodilator. And the dose wherever there is a bronchodilator, we are going to give the dose pertaining to the bronchodilators. And which are the bronchodilators available in oral preparations are salbutamol. And the dosage is 0.1 milligram per kilogram per dose, which is given thrice in a day. The levosalbutamol is usually given a half dose, as we see is 0.05 milligram per kilogram per dose. And terbutaline is also available, but we usually avoid that because of the side effect like tachycardia. Mucolytics like ambroxol, bromexine. Ambroxol is available as a drop formulation as well as syrup formulation. The expectorant like ammonium chloride and sodium citrate are available along with the bronchodilators and mucolytics. The decongestant is available along with antihistamine, and there are suppressants. Now, in pediatric population, there are hardly any reason why we should suppress the cough. Cough is telling us something. We try to treat the cause rather than suppress something which is trying to tell us something. So there are old preparations like Coscopine, the peripherally acting cough suppressant like dextromethorphan, which is given in 1 to 2 milligram per kilogram per day in two divided doses. The butarimate, which is a newer cough suppressant, which is again a peripheral acting suppressant, which is given into 5 ml TDS in 3 to 6 years old. In more than 6 years, we gave the double dose. Then levodopa is another newer cough suppressant, and latest which is available, which is widely used in Western worlds on a OTC as a OTC product is glycerol. The dose is between 3 months to 1 year is 5 ml 3 times in a day. and more than 1 year is 10 ml 3 times in a day. Now, the practical use of this medications is yet to, we are just still starting. As far as asthma is concerned, the salbutamol dose in a nebulized form is 0.15 milligram per dose. You should know that salbutamol has side effects in form of tremors. The meter dose inhaler, if we give in acute exacerbations, could be 2 to 4 puffs. In case of salbutamol, exactly half dose is 0.075 milligram per kilogram. One should know that in less than a year, I mean 6 months, there are no salbutamol receptors. Therefore, use of salbutamol as oral preparation is worthless. So what we do is we give ipratropium bromide. The dose in neonate is 100 microgram, and while in children is 125 to 250 microgram. The long-acting bronchodilators like salmeterol and formoterol is available in meter dose inhaler. The doses is 50 microgram and 12 microgram respectively. The meter dose inhaler formulation of budesonide and fluticasone used in maintenance dose as far as asthma is concerned starts from 100 to 400 as far as budesonide is concerned, and 50 to 500 microgram as far as fluticasone is concerned. The dose depends upon the severity and the response which we get from the patient. Then there is leukotriene antagonist, which is montelukast, and it is used along with the inhalation therapy, and the doses are between 2 to 5 years, or sometimes we can give more than 6 months, is 4 milligram once in a day, usually given in the evening. The dose is 5 milligram in the evening from 5 to 14 years, while in more than 14 years is the same adult dose we give 10 milligram once in a day. We come to antihistamine. There are antihistamine which are sedative, and there are antihistamine which are non-sedative. Now, the commonest antihistamine which we use as far as acute urticaria is concerned is hydroxyzine. The dose is 0.5 milligram per kilogram per dose. It could be given twice in a day. It could be given even 4 times in a day. But hydroxyzine causes a lot of sedation. Hydroxyzine can also cause oliguria. Therefore, one should remember that child has to be hydrated well. There are 2 other antihistamine, which is cetirizine and levocetirizine, which are almost similar. The literature says that levocetirizine has got little less sedative effect than cetirizine. It could be given as early as 6 months to 2 years, but the indications usually you should define. Only rhinorrhea should not be the reason for us to give cetirizine and levocetirizine, because it has got after effects. So in a school-going child, you should avoid, say, antihistamine, which are sedative. There is CPM, which is a commonest antihistamine used with decongestant, cough suppressants, and CPM is used in the dose of 0.2 milligram per kilogram. And again, it has got after effects. Therefore, don't give it 3 times or 4 times in a day, because the child will doze off. So ideally, you give afternoon and night, where you are not bothered about the sleep of the child. There are 2 antihistamines which don't cross the blood-brain barrier, are fexofenadine, which is relatively old now. We can give as early as 6 months, and the dose is 15 milligram twice in a day. Between 2 to 12 years, it is 30 milligrams. More than 12 years is 60 milligram, or twice in a day, or a straight adult dose of 120 milligram. The syrup is available in form of 5 ml, which is 30 milligram. The tablets are available in 120 milligram. In little older child with urticaria or allergic rhinitis, we can give the dose of 180 milligrams also. Very commonly written medications for, say, vomiting are the peripherally acting medicine called domperidone, and the dose is 0.2 to 0.5 milligram per kilogram per dose. We can give thrice in a day, and small babies who come, the simple dose is 1 drop per kg per dose. So 5 kg or 8 kg baby comes, we are giving 5 drops or 8 drops respectively. The most important part in anti-emetics is that the medicine should be given 45 minutes to 1 hour prior to giving food. Then only the medicine will act. Ondansetron, the commonly written antiemetic, is the dose of 0.2 milligram per kilogram per dose, which could be given 8 hourly. And granisetron, which usually we give just before the chemotherapy. The availability part of ondansetron is available in syrup form, it is available in tablet form, it is available in mouth dissolving form, and it is available in the strip form where kept on tongue, which dissolves in say 5 seconds. The commonest drugs which we use for fever is paracetamol. Now, the paracetamol is given in the dose of 15 milligram per kilogram per dose. The half-life of paracetamol is around 4 to 6 hours. Therefore, we can give paracetamol 6 hourly. Paracetamol is available in drop form, syrup form. Syrup is available in 120 or 125 milligram. It is available in 250, and recently the one company has come out with 500 milligram per 5 ml also. The other potent NSAIDs which could be used for fever in special circumstances is ibuprofen, and the dose is 10 milligram per kilogram per dose. But here the half-life is around 8 to 10 hours. Therefore, paracetamol should not be given more than 3 times in 24 hours. Commonest use medication which we see is mefenamic acid, but mind that this medicine is only given in children above 14 years. You should avoid giving mefenamic less than 14 years, and always avoid giving combinations of mefenamic acid and paracetamol. It has got no sense. The anti-malarial nowadays, we are seeing malarias. So Vivax malaria, we want to treat, we give chloroquine, and the chloroquine, the total dose is 25 milligram per kilogram per base. The day one, in the olden days, we used to give 10 milligram per kilogram start, followed by 5 milligram after 6 hours. The day two was 5 milligram, day three were 5 milligram. The latest WHO, we can give day one 10 milligram per kilogram per dose, day two 10 milligram per kilogram per dose, and day three is 5 milligram per kilogram per dose. Now, chloroquine is available in syrup form. It is also available in tablet form. One thing about chloroquine is chloroquine causes a lot of gastritis. So person suffering from vomiting for giving chloroquine, always give antacids or PPI inhibitors. If you have a falciparum malaria, there is preparation which is artemether plus lumefantrine, and the doses are weight dependent. Between 5 and 15 is 20 plus 120. 15 to 25 is 40 plus 250, 40, 25 to 35 kgs is 60 plus 360. More than 35 kgs, we consider that as adult, and we give the adult dose. The dose is twice in a day for 3 days. Now in malaria, we have to do a radical cure. And for radical cure, we have to give primaquine. And before giving primaquine, we have to see G6PD deficiency. In patients who don't have G6PD deficiency, we have to give primaquine in the dose of 0.3 milligram per kilogram per dose, and it is given once in a day for 14 days. In G6PD deficient kid, the dose is 0.75 milligram per kilogram weekly for 8 weeks. Now, the above dose of 0.3 milligram per kilogram per dose is true for Vivax malaria. If someone has falciparum, yet we give primaquine in a dose of 0.9 milligram per kilogram, it's stat dose. We come to antibiotics, and the commonest use antibiotics is a penicillin group of antibiotics, which is amoxicillin in a dose of 20 to 40 milligram per kilogram per day in 3 divided doses. And there is more advanced combination of amoxicillin and clavulanic acid, which is given in a dose of 20 to 40 milligram per kilogram per day. There is also, we give high doses as high as 90 milligram per kilogram in patients with otitis media. There is cephalosporin groups of antibiotic. We give commonly cefixime. While amoxicillin and clavulanic acid is given for upper respiratory tract infection, it covers more of a gram-positive bacteria. It could also be given for enteric fever, but cefixime should not be given for upper respiratory tract infection because it doesn't cover staph. Cefixime is more of a gram-negative coverage, and its common indications are, say, enteric fever, in gastroenteritis, in urinary tract infection. The dose is 8 milligram to kilogram per day in 2 divided doses, while in enteric fever, we give double the dose. So the dose is 10 milligram per kilogram per dose, or say 20 milligram per kilogram per day in two divided doses. The another sister of cefixime is cefodoxime, which is given 10 milligram per kilogram per day. It covers the gram-positive bacteria, but it is somewhat inferior to the combination of amoxicillin clavulanic acid. There is another wonder drug called cefuroxime, which is used for gram-positive as well as gram-negative. The doses is 30 milligram per kilogram per day in two divided doses. But the main disadvantage of cefuroxime is the molecule itself is extremely bitter. So the children usually don't accept, and they usually vomit. Cefaclor, again used for upper respiratory tract infection and otitis media. The dose is 20 to 40 milligram per kilogram per day in two divided doses. But cefaclor has got very narrow spectrum of action. Again, used like water, macrolide group of antibiotics. In olden days, we used to do erythromycin, which is given in a dose of 50 milligram per kilogram per day in 4 divided doses. And that was the reason for not writing so much of erythromycin, though I do write in infancy, where azithromycin, where we cannot try it in less than 6 months. So azithromycin is 10 milligram per kilogram per dose given once in a day, while in patients with enteric fever, we have to give the double dose, that is 10 milligram per kilogram per dose, is given twice in a day, where clarithromycin, the dose is around 15 milligram per kilogram per day in two divided doses. Well, nowadays, clarithromycin could be given as a single dose as 15 milligram per kilogram per dose. The difference between azithro and clarithro is that azithromycin is bacteriostatic, while clarithromycin is bactericidal. The fluoroquinolone group, which is ofloxacin, ciprofloxacin, and levofloxacin, is not a main use of drug, not a primary drug usage, because it has got the side effect, can damage the cartilage. So it is used in special circumstances, not first drug of choice, but it could be used for n number of conditions like enteric fever. It could be used for UTI. It could be used for gastroenteritis. Linezolid, again, in patients with otitis media, and it's showing MRSA, we give the dose of 10 milligram per kilogram per dose given thrice in a day. And wonder drug, utromoxazole, the dose is 8 milligram per kilogram per day given twice in a day, but and the dose is base of dimethoprim. And utromoxazole again has got, it's usually used with caution. And doxycycline, which could be used more than 6 years in a dose of 5 milligram per kilogram per day in two divided doses, the indication being rickettsia. Now, again, as we are using a lot of antibiotics, we use a lot of antivirals too, because these are the days where we are seeing in and out virals. And we are using oseltamivir, and it could be used as early as less than 6 months, and 3 months, sorry. And the dose is calculated weight-wise also. Less than 15 kgs is 30 milligrams BD. More than 15 to 23 kgs is 45 milligram BD. More than 23 to 40 kgs is 60. And more than 40 is the adult dose. So the concentration is 12 milligram per ml. So in less than 15 kgs, we use 2.5 ml, then 3.5 ml, 5 ml, and 6.5 ml. In less than 3 months, where it is indicated, we use 1 ml BD, 1.8 ml BD, and 2.2 ml BD. Acyclovir is used in patients with herpes zoster. The dose is 20 milligram per kilogram per dose, given 4 times in a day for 5 days. Now, patients with gastro, we use metronidazole. The doses, amoebiasis, indications are amoebiasis, and the doses is 30 to 50 milligram per kilogram per day in 3 divided doses for 7 to 10 days. And the underdiagnosed condition of giardia, the dose is 15 milligram per kilogram per day in 3 divided doses for 5 to 7 days. The other sister of metronidazole is nitazoxanide. And this is BD. This is 1 to 3 years. We give 100 milligram twice in a day. In 3 to 12 years, we give 200 milligram twice in a day, and more than 12 years, we give 500 milligram BD, that is the adult dose. Now, albendazole, it's a deworming medication. We usually give to all kids more than 1.5 years. We give twice in a year, that is the WHO recommendation. And between less than 3 years, we give 200 milligram to start with and 200 milligram after 15 days. And after 3 years, it's a universal adult dose is 400 milligram single dose. Now here, what we have to understand is we have to avoid combinations with antibiotic, especially metronidazole, and there is another antiprotozoal called ornidazole. So there are n number of combinations available with ofloxacin, metronidazole, ciprofloxacin, metronidazole, ofloxacin, and ornidazole. It has got no rationale, no recommendation. Both half-lives are different. Plain ornidazole is extremely bitter to taste, and it does not is not palatable with the child. Coming to the anti-epileptics, the clobazam and midazolam, which we used on a OPD basis. Clobazam is used in a dose of 0.5 milligram per kilogram per dose, and it is used in febrile seizures. And midazolam nasal spray, if someone comes convulsing, the dose is 0.3 milligram per kilogram per dose. Talking about antacid, there is H2 receptor antagonist and the proton pump inhibitors. Commonly, we use lansoprazole, pantoprazole, omeprazole, and newly recommended esomeprazole in patients with gastritis, peptic ulcers, and even GER and GERD. Usually, as we see, this proton pump inhibitors and H2 receptor antagonists should be given 1 hour before the meals. So lansoprazole is the dose of 1 milligram per kilogram per day. Once in a day before food, it is available in form of 15 milligram and 30 milligram of a dispersible tablet. Pantoprazole, again, the same is 1 milligram per kilogram per dose once in a day. It is available in form of 20 milligram dispersible tablet, 20 milligram tablet, and 40 milligram tablet. While omeprazole recently come out with the dispersible tablet, mouth dissolving tablet, 0.7 milligram per kilogram per dose, given once in a day. Ranitidine is available in form of syrup and tablets. The dose is 1 milligram per kilogram per dose, given twice in a day. So there are preparations. We talk about anti-tuberculosis treatment. Again, primary line of management, INH, rifampicin, pyrazinamide, and ethambutol. The dose, everyone knows, is 10 to 15 milligram per kilogram. 15 to 20 milligram per kilogram is rifampicin. 30 to 40 milligram per kilogram is pyrazinamide, and ethambutol is 20 milligram per kilogram. It is to be given before breakfast, and don't forget to write pyridoxine. The dose is 10 milligram per day. Talking about corticosteroids, what are the indications which we can use in say day-to-day practice or say in OPD patients? The first indication is again acute exacerbation of bronchial asthma, and second indication is nephrotic syndrome. The prednisolone, the dose is 1 to 2 milligram per kilogram per day in divided doses, is available in syrup form as well as tablet form. Deflazacort, the dose is 0.25 to 1.5 milligram per kilogram per day in 2 to 3 divided doses. Now, the steroid should be given with caution. Number of days should be mentioned. It should be given post meals. The side effects should be explained, and it should be always it should be given along with say antacids and say or proton pump inhibitors. So there's dexamethasone, which is given intramuscularly in cases of laryngotracheobronchitis, which is also called PRU. The dose is 0.6 milligram per kilogram per dose, and usually we give sometimes in OPD or sometimes in a daycare. So there are antidiarrheals. So there are plenty of antidiarrheals available, and which we should give is a $1,000,000 question. So there are probiotics in form of Lactobacillus acidophilus, Saccharomyces boulardii, Bacillus collozi, and Lactobacillus rhamnosus GG, and newly available Bacillus subtilis. Now, they are available separately, but there are plenty of combinations which we should avoid because there is no rationale. The dose is exactly not defined. Lactobacillus acidophilus could be used in infancy as well as Bacillus collozi, used in acute diarrhea, viral diarrhea, bacillary dysentery, as well as antibiotic-associated diarrhea. Saccharomyces boulardii is available in form of sachet. Bacillus clausii is available in liquid form, which is colorless, tasteless, odorless. Lactobacillus rhamnosus GG is available again in a sachet form. Now, there are plenty of, again, probiotics which are used in different conditions, but recommendation by Nelson is for Lactobacillus acidophilus, Saccharomyces boulardii, and Bacillus clausii. We talk about the diarrhea, we talk about constipation. So we see constipation on a daily basis because of plenty of reasons. And what we give, apart from is one is lactulose, which is given in a dose of 1 ml per kg per day in two divided doses, and the newly available, which is polyglycol, which is given in doses of 0.8 milligram per kilogram per day in two divided doses. We can give as a single dose too. The lactitol is the 2 teaspoons is 10 milligram and which is given once at night. Now, PEG is a wonder drug. Nowadays, the recommended highly could be given once at night. It is available in powder form or ready to drink form also. It is available in concentrated form also, which we have to dilute with water. But again, don't forget, as far as constipation goes, constipation is functional. Medicine are just going to help you briefly. The most important part about treating constipation is about the dietary management as well as the toilet training. Don't forget that, because then medicine will go on for a long time. ORS, why I included ORS? Because most of the patients don't know how to prepare ORS. So only WHO certified ORS should be prescribed. There are n number of fancy preparations which have got irrational concentrations which can lead to hypernatremia. We should avoid that. ORS is available in form of 1 liter and 250 ml of concentration. The method of preparation should be explained and quantity and frequency should be explained to the parents. And all this is to avoid hypo or hypernatremia. We come to the nutritional supplements. What we give commonly in day-to-day OPD patients is calcium, vitamin D, iron, and zinc. Now, there are various calcium preparations available. What is important is the dose. Here in nutritional supplements, we stick to our dose. In calcium deficiency, we give in the dose of 75 to 100 milligram per kilogram per day in 3-weighted doses. What we have to take into consideration is that how much concentration of elemental calcium is there in the bottle and how much amount of vitamin D is there in the bottle. Our aim is to give less medications as far as possible to avoid defaultation. The calcium phosphorus ratio should be 2:1. So there are various preparations of calcium available in different salts. So there are calcium preparation available with 82 milligram of calcium with 200 international unit of vitamin D in 5 ml. There are calcium preparations available in 250 milligram of say elemental calcium and 200 IU of vitamin D. And there are preparation of 300 and 300 of calcium and vitamin D each. So we have to, rationally, and we have to stick to our dose. About giving only vitamin D, as we all know, is that the recommended dietary allowance is 400 IU per day from birth to 1 year, 600 IU from above 1 year. And in vitamin deficiency, D deficiency, the current recommendation, as far as I know, is 60,000 in the units given alternate week for 8 weeks. Coming to iron, we give as therapy, we give as prevention. Again, as I said, we stick to the dose. In maintenance part, in preventing part, the dose is 3 milligram per kilogram per day in 2 divided doses. Why divided doses? Because the absorption is better. We have to consider here the elemental iron, and the maintenance or the preventive part is given in patients with low birth weight, in premature babies, in babies who are not privileged of breast milk. And in therapeutic, as far as iron deficiency anemia is concerned, the dose is 6 milligram per kilogram per day in 2 divided doses. Now, various iron salts are available, from colloidal iron to different ferrous salts like ferrous ascorbate, ferrous fumarate, ferrous sulfate, ferrous gluconate, ferrous succinate. There is iron polymaltose complex, there is carbonyl iron, there is iron pyrophosphate. Now, wish to give give anyone. There are studies which says that some salts have got better bioavailability, some have got low bioavailability. Whatever you give, we stick to our dose. Again, not to forget that iron has got its own side effect. So iron can give rise to constipation or diarrhea. Iron can give rise to, say, staining of teeth. Now, therefore, the less the quantity, better the iron. So therefore, what I do is that to give concentrated iron. So there is formulation which has 250 milligram of elemental iron in 5 ml. So for a 10 kg baby, we just have to give zero point 0.5 ml twice in a day. And one bottle of 200 ml will last for 6 months. So the iron deficiency therapy is for 6 months. So I am sure that the patient is going to give their kid 6 months of treatment. The zinc, which is given in two conditions. One is acute diarrhea and second is LRTI. The first, the less than 6 months, the dose is 10 milligram per day. More than 6 months, the dose is 20 milligram per day. And zinc is given for 14 days. There are antispasmodic given for acute abdominal pain. मेरा पेट में दर्द है. A lot of patients come, but again, which medication to give to whom? There are two antispasmodics available. One is dicyclomine and second is drotaverine. Now, I would be very, very worried to give dicyclomine to even a child up to 1 year because dicyclomine has got its own side effects. Dicyclomine, if given for, say, colics in less than 6 months, have got incidences of apnea. It can give rise to a lot of sedation. So I usually don't advise to give dicyclomine in less than 6 months. Little older kid, one can give dicyclomine in dose of 5 milligram per dose. Children, we can give up to 10 milligram per dose. The drotaverine, which is also an antispasmodic, could be given in a dose of 20 milligram to 1 to 5 years and 40 milligram between 6 and 12 years. In antispasmodic, what we give is your dill oil and other carminatives, which are very, very safe to be given. So shortly, we see few cases and we wind up. The case one is 7-year-old boy with fever and throat pains in 2 days. Have been diagnosed with acute tonsillitis. The weight of the child is 20 kgs. The treatment, how we are going to write is syrup paracetamol. Now, should we give paracetamol round the clock? Why we need to suppress the fever? Because fever is going to tell us how our treatment is going to take care of his infection. So paracetamol should be given only on SOS basis. So the dose for a 20 kg, if we give 250 milligram of 5 ml, is 6 milligram, which could be given 6 hourly only if temperature is more than 99. We advocate the parent to monitor the temperature and we give a proper dose of, say, 40 milligram per kilogram per day. So amoxicillin plus clavulanic acid, it is available in 456 formulation. The dose is 5 ml twice in a day for 6 days. Now, the second case is a 7-year-old girl who's been diagnosed with UTI, again a 20 kgs. We have to give cefixime, which is again available in 100 milligram per 5 ml. Here we won't advocate 50 milligram because the dose would be double. We have to give less dose for better acceptance. The dose is 4 ml twice in a day for 7 days. Again, paracetamol is given on SOS basis. The same girl who suffers from enteric fever, the dose of cefixime is double. Again, there are formulations available 200 milligram per 5 ml. If it is easily available, you can give that. The dose would be then 5 ml twice in a day. Otherwise, 100 milligram per 5 ml, the dose would be 10 ml twice in a day for 7 days. And if resistant and we need to add azithromycin, the dose as we have seen is double the dose. So azithromycin, we bring 200 milligram per 5 ml formulation and we give 5 ml twice in a day. The duration of therapy for enteric fever is 5 days, 5 to 10 days. So what are the take-home messages is that whenever we write doses, we have to calculate. There is no harm in calculating. There is no harm in using calculators. In Western world, all doctors use calculators. Nowadays, there are a lot of apps. Nowadays, AI does everything for us. So calculate the dose properly. The dose calculation should be precise to avoid overdosing as well as underdosing. And learning tables helps. Doctors are very, very weak in mathematics, and only learning tables will help them as far as calculation of pediatric doses is concerned. Write your prescription properly, because most of the errors occur in that. If your handwriting is weak, you write in capital letters. The more number of patients, the worse is our handwriting. The best part is to print out the prescription. And most important thing about doses in pediatrics is how much to take, when to take, and how to take. Thank you so much for patience listening.
Sir, there are some questions in the chat box if you take them, sir.
We'll take now or we'll take later?
So now only.
Fine, very good. Give me some time. Let me see.
Question is, when do we repeat albendazole after 400 single dose?
Yeah, so the WHO recommendation is twice in a year. Twice in a year we give.
The second question is about the dosage of ranitidine. I'll just tell you the exact questions.
Yeah, so I have written it. So 1 milligram per kilogram per day in 2 divided doses.
If any of the participants have any other questions or any follow-up questions on the answers which sir has given, you all can ask now. I think so. That's it. Thank you so much, Dr. Bapaye.
Thank you so much.
So Dr. Chaya Kusha was asking if you can share the slides. Ma'am, we'll let you know in some time if we can share the slides. Our next speaker, thank you, sir. Our next speaker is Dr. Nehal. Dr. Nehal Shah. He is a pediatrician at SRCC Children's Hospital. Welcome, Dr. Nehal. He'll be talking about approach to a child with fever and rash.
Okay, so good afternoon, everyone. Hope everyone can see me, hear me. And after the wonderful lecture by Dr. Bapaye, I hope I keep you all interested as much as he did. Okay, so now approach to child with fever and rash. Okay, wait. Okay, my slide is hung. Okay, my
Slides are visible. You're audible, but if you can just try changing the slide so that we can be sure.
no, I'm trying to go to the next slide, but it's not happening. Wait, let me share it again and see. Just a second.
All right.
Okay. No, my slides are not moving for some reason.
Dr. Nehal, just give us a moment.
Yeah, just check. Yeah, and can everyone hear me?
You're audible. We can hear you.
Yeah. Okay, so a very common problem which we face every day as a pediatrician, as a general practitioner, a child with fever and rash. So, just a second. Okay, wait now, something has again gone amiss. Extremely sorry, but this thing is getting. No. Now I cannot see my PPT. Wow. Okay, here it. Just give me a second. Okay, now I'm done. Okay. So fever with rash is the most common problem that we come across in the children, both in our OPDs. It's very common by dermatologists, pediatricians, and the most commonly the first point of contact of the most people, the general practitioners. Now, most of them are viral exanthems, which are much of clinical significance. They are mainly self-limiting. They do not need to know much. But what we need to know is differentiating the point where they are significant versus not significant. So in this presentation, we'll have a just superficial overview of the infections and the non-infectious causes of fever with rash in children, how to diagnose them, and special emphasis on Indian scenarios. Now, fever with exanthem is the most common in childhood, a very common cause of anxiety amongst parents because they are not used to see this on day-to-day basis, and this is something very unusual and abnormal for them, and that makes them panic. Most of them were viral exanthems without much of a clinical significance. Parents just needs reassurance, a symptomatic and supportive therapy in such cases. But as a physicians and the caretakers, we must be aware of all the distinguishing features of the serious illnesses, which may be associated with any major complications, which will imply to some morbidity and mortality. Now, the most common causes of infections, the viral infections, measles, rubella, your varicella, which is chickenpox, adenovirus, herpes virus, 1 and 2, HHV6, 7, Epstein-Barr, Coxsackie, dengue, chikungunya, influenza A and B, hepatitis B, Lassa, Marburg, Ebola, Hanta, common causes, but not in our Indian scenario, but we do see occasional case. Most common, again, bacterial infections are good old Staphylococcus, group A Streptococcus, Neisseria, Listeria, Salmonella typhi, which is most common in the current season, Yersinia group of bacteria, Bartonella group, Borrelia, Leptospira, rickettsial infections, which are not very common, but we do see odd cases once in a while of rickettsial infections. Now, the non-infectious causes, which are very important. The most common ones in non-infections are systemic juvenile idiopathic arthritis, lupus, juvenile dermatomyositis, Kawasaki disease, Henoch colon purpura, polyarthritis nodosa, vaginous granulomatosis, and there are many more, but these are the ones which are very common in pediatrics. And the most important are the drug hypersensitivity rashes, Steven-Johnson syndrome, toxic epidermal necrolysis, acute generalized xanthomatous pustulosis, drug reaction with eosinophilia and systemic symptoms, which we call as a DRESS syndrome, and leukocytoclastic vasculitis. Now, this is the basic rashes that we commonly come across. A bulla, which is a circumscribed collection of fluid, usually more than 1 centimeter. A macule, one of the most common type of rash, which is circular flat discoloration, commonly less than 1 centimeter, brown, bluish, reddish, or sometimes even hypopigmented. It could be of any color basically. A nodule, which is a circular elevated solid lesion more than 1 centimeter. A patch, which is circumscribed, flat, discolor, and more than 1 centimeter. Papule, again, very common type of rash, which is superficial, solid, elevated, less than half centimeter. Color could be varying according to the illness it is being caused by. Plaques, superficial, solid flat top, more than 1 centimeter. Pustules, vesicles, wheal, scales, crust, fissures, excoriation, erosion, lichenification, and scarring. So these are the most common type of skin lesions and rashes that we commonly come across. Now let's see into brief of some of the common ones. Now macular or maculopapular rash. So this is basically a post fever. You can see, you must have seen lots of kids having this kind of picture or rash over the body, or sometimes just generalized either to a specific parts, usually face or a neck, or sometimes all over the trunk. So most common causes of such rash is measles, rubella, dengue, some drug rashes, infectious mononucleosis caused by EBV, chikungunya, adenovirus infections, enteroviral infections, brucellosis, not so very common, but once in a while we do see it, rickettsial infections, and in non-infectious causes like lupus and systemic onset JI. All of them can give you fever with this kind of maculopapular rash. Now, diffuse erythema or scarlatiform rash with or without discommission. So, your scarlet fever, which is most common differential diagnosis of Kawasaki disease, they present with this kind of diffuse erythematous rash and maybe with discommission or without discommission. Then Steven-Johnson syndrome, drug-induced toxic ectodermolysis, streptococcal toxic shock syndrome, and Kawasaki. They all are known to have similar presentations. Vesicular rash, which we commonly see with chickenpox, herpes, enteroviral infections, and sometimes even in Steven-Johnson syndromes. And petechial or purpuric rash, which we see in meningococcemia, dengue fever, chikungunya fever. Then nodular rash, which we see in tuberculosis, the erythema nodosum is the first picture that we are seeing, and erythema multiforme, which are like this target lesions like things circular, are seen many times in mycoplasma and herpes simplex viruses. Now, what are the differential diagnoses of these rashes? So, our approach should be firstly based on the associated clinical symptoms. So, we usually a meticulous history taking is the most important in this. So, a respiratory tract infections is usually present in history with most of the viral infections like measles, rubella, varicella, adenoviruses, Coxsackie, EBV, scarlet fever. The parents give a usual history of 2-3 days of high grade fever associated with some cough, cold, if not obvious, some runny nose, child being dull during the episode, again gets back active once fever is down. So this points towards a common viral infection. Then acute onset. The fevers which are usually high grade, very high grade, 103, 104 in first 22 to first 24 to 48 hours are usually either viral, urine infections, or malaria. The bacterial infections commonly do not cause such a high grade fever in first or second day of the illness. Now, fever with insidious onset. Most of these are not commonly infectious causes. They are generally non-infectious, which evolve or develop over a period of days to weeks. So which most common ones are lupus, juvenile dermatomyositis, polyarthritis nodosa, vaginous granulomatosis. Then you have something like a relapsing fever, which child has fever for a few days, then it's better for a few days, again the fever recurs. So in Borrelia, Quintana, such kind of rare or maybe not so common infection, you have this kind of features. Then fever associated with joint involvement. Many a times a single joint or a multiple joint. So polyarthritis means more than one joint or multiple joints are most common with chikungunya, dengue, leptospira, systemic onset juvenile arthritis, lupus, and polyarthritis nodosa. And fever with large joint involvements are commonly acute rheumatic fever, Henoch's colon purpura, and juvenile idiopathic arthritis. Now, another aspect of fever with rash, you should always look for whether it is associated with hepatosplenomegaly and lymphadenopathy. So fever, rash, hepatosplenomegaly with lymphadenopathy, the most common infections are infectious mononucleosis, leptospira, Borrelia, and not very common, but definitely we see one case in a while is brucellosis. Then hemorrhagic manifestation in fever with rash. So basically any infections or illnesses causing low platelets, causing hemorrhagics, manifestation like dengue, chikungunya, severe meningococcemia, or a Henoch's colon purpura can have it. And finally, fever rash with multi-organ failure, hypotension, and shock. This we see commonly in infections like dengue, meningococcemia, leptospira, and chikungunya, and non-infectious causes like toxic shock syndrome. Now, some pictures basically, which we see commonly, is what we call as fifth disease, which is a slap chick appearance. You can nicely see a reddish hue of chicks as if someone has slapped the kid. Again, you get a history of some coryza, some cold, fever on and off for past 2-3 days, and the rash appears. And rash appears and the fever starts subsiding, which is very typical of this. You can see the two different illnesses in this. So one on the right side is basically palatal petechiae. You can see those red petechial spots on the palate. So this is very commonly seen in Epstein-Barr viruses, in an adolescent kid, in staying in a crowded places. It's very important. You can see this commonly. And similar kind of petechiae, not exactly petechiae, you can see mucositis on the palate in the lupus case. So it's always important that any fever patient, you have to examine the throat, which is very important. And again, on left hand side, you see there are white laterally ulcer like things. So this is herpangina, which is caused by the Coxsackie virus. Typical history, 2-3 days of high grade fever, not responding much, no other symptoms. A young kid, a preschool kid, and you open the mouth and you see this ulcers. And there's a typical history, the child has not been able to eat much, or sometimes has drooling also because of this kind of ulcers. Then again on the right hand side, it's an adolescent girl. This is not a slap chick appearance. This is a malar rash of lupus. You can see it's typical on the nose of the bridge involving the cheeks and the so-called butterfly rash. Then on the left-hand side, what you can see right now is the manifestations of Kawasaki. You can see some rash on the face. You can see the conjunctival congestion. You can see cracked lips. You can see strawberry tongue. You can see little puffed up hand, which happens within after maybe first week, and then slowly the desquamation also starts. Then your legs, you can see, which is commonly maculopapular in case of Kawasaki disease.
Not audible.
Am I audible?
Now, yes.
Yes.
Now?
Yes.
No, so when was I not audible? I mean,
When your take care slide came up.
okay.
Yes.
So I think I was not audible at right time.
Start with the take care, Nehal.
Sir, that's all done, sir.
Was that your last slide?
Yes, sir. I
Okay,
just
fine.
superficially covered all the
Okay.
basic
Okay.
things.
Okay, thank you. If there are any questions from the
Any
audience.
questions, please feel free
Any
to ask.
questions? We don't have any questions in the chat box as of now. But
Okay.
Nehal, Dr. Nehal, in case anyone has, then we'll get back at the
Yeah,
end
yeah,
of the list of
I'm very much,
speakers.
yes, I'm very much around. So any questions?
Yes.
Rujul, can I add a comment, Nehal?
Of course,
Yes,
sir.
sir. Sure.
Yeah. So since I can see that first of all, wonderful presentation. Those images really killed it. They were really great. But since there are over 100 people around, I must tell everyone over here that any child who comes with fever and rash needs to be reported to the BMC so that they can rule out a measles outbreak that may be happening. So any child fever with rash, even if you know it is dengue, even if you know it is a rheumatic case, even if you know it's a bacterial thing, a fever with rash has to be reported. You don't have to do much. Just call up your local primary health center people or the WHO people or even the person who takes the vaccination numbers from you from the BMC, and they will do the rest. But that's extremely important that we report all cases of fever with rash to the BMC.
Thank you, Dr. Amin. I think that was very, very, very important message for everybody.
We have some questions in the chat box.
Yes, please. Let me just read them. Ideal treatment for first question, which I can see is ideal treatment for chicken pox. So a child less than 1 year of age will definitely need to take acyclovir for 5 days because high risk infants are at high risk for a complication. And anything more than 1 year, it's just symptomatic. Paracetamol or ibuprofen for fever as needed. Lactocalamine lotion for local application for soothing or itching. And I think that should be, nothing more should be needed for chickenpox. And of course, isolation from the people around and high risk people around. And the next question I can read here is commonest investigations, tropical fever panel or a virus panel. Honestly, 3 to 4 days of fever, which you are very likely or confirmed that it is a viral infection, generally does not need any investigation, especially to diagnose. We do investigation in case if we are suspecting any complications or if you have a really, really sick child on the hands. So any fever more than 3 days, but child clinically looks good, I think we can avoid investigations. Just give symptomatic paracetamol, ibuprofen, plenty of hydration, explain the parents the red flags and the warning signs with which they should report back, and most of them would settle down in 3 to 5 days. Many children get seizures, so that I believe, sir, you are asking is febrile seizure. That is a completely different ball game. So in that case, all you need to do is control the fever. It's usually sudden rise in temperature that is not been taken up well by the body and they throw a fit. So in that case, always fever control measure is the first thing that you do. Get down the fever by ibuprofen, sponging, bathing, whichever modes is available at your nearby. And in case of a medical treatment for a seizure, there are midazolam sprays available in case if your seizures are lasting more than 3 minutes, which can be repeated 2 times. And beyond that, if seizures still persist, please reach out to near medical center for the further help, which very likely would be IV medication and monitoring or maybe even admission. Any more questions?
I think no more questions. In case there are any, they'll put up on the chat box.
Sure.
Our next speaker is Dr. Paresh Desai, sir. Sir will be talking about fever in children. Sir is our senior pediatrician at SRCC Children's Hospital. Welcome, sir.
Good afternoon, everyone. So Mandar and Nehal have made my job easy. So they have warmed up the audience. And let's start. I'm going to make my presentation short, only about common problems. And let's see if it appeals to everybody. So from a family doctor's perspective, 30 to 40% of patients who come usually to the GP are children. People are worried about children more than their parents. So the adults, you can wait 3-4 days. Children, they will not wait. They will always be in a hurry, especially if there are grandparents. So here is a practical, age-based and etiology-based approach to deal with this. So let's talk first about newborn child. That also let's divide before the age of 7 days and after the age of 7 days. Newborns are the first 1 month children or less. And the first 7 days, usually the infections or whatever problem fever is there is almost always because of the mother. More than 7 days, it's from the hospital where the baby was born. It can be the home in the terms of people who visit, and then malish wali bais or the jhapa bais and whoever. So their kind of ignorance. This is best managed by an expert. If you have a 7-day or 15-day child with high fever, I think the referral is the best option, and one should not try to do too many things. And what is the suspicion that this is really bad? See, children will not tell you anything at this age. So it's usually child is not accepting feeds, is lying down very, very irritable, inconsolable. And if the child gets seizures, of course, the parents will not wait for you. They will run to the hospital anyway. So this should not be managed in the general practitioner setting. Good clues will be a good history. If you know the antenatal ultrasound, what the prenatal history was, whether there were lots of problems, there was, like early rupture of membranes and so on, prolonged labor, history of previous births, exposure to somebody who was sick, whether the child is not breastfed. Non-breastfed children are highly more prone. If the jaundice and is more than what is expected and the umbilical stump looks infected, that is a clue. Excessive vomiting, not being able to console the child. And if you see the tone and the perfusion and the capillary refill, if you find that it's bad, run, send the child. A depressed fontanelle or a very bulging fontanelle must have a pediatric referral, usually hospitalization, but without that also, if the pediatrician is convinced, it's not needed. Now let's come to the infant, 1 to 2 months. 6 to 10% of these children have serious infection, and the most common and one of the most important things and which is missed and can't be seen is UTI. Especially if there is a male child, it is a serious UTI. The viral infections, bronchiolitis, especially family history is there. Warning signs here would be a heart rate which exceeds 160 even if there is no fever, and respiratory rate more than 60, whatever the reason. An ill appearance, excessive vomiting, tachypnea, retractions, a very delayed capillary refill. If you're using all the abdominal and the chest and the accessory muscles of respiration, distension of the tummy, a very bad rash. And if the umbilical stump is still there at more than 4 weeks of age, that means there may be an infection there. A full sepsis workout should be maybe needed, and most important warning signs if the WBC is excess of 15,000 per cubic millimeter, and if there are more than 1,500 bands are immature WBCs. So you are sending the children to war. That's not a good thing. Low risk, such an infant who is well appearing, is feeding well on the breast, there is no full adverse history in the delivery, there's a good weight gain, there is no dehydration, doesn't seem like a ear infection, you don't see too many boils or pustules. A urine routine, if you can do, is less than 10 pus cells. And if you're going to do a blood test, low CRP, CRP and procalcitonin if they are not raised. Fever in bigger children is almost like Nehal said, self-resolving, viral. Important to deal with children with history of febrile convulsions. There you have to bring the fever down more aggressively. Drugs used to bring down fever should be in the right dose, which Mandar has emphasized. Paracetamol and ibuprofen should be the only drugs used. Please do not use mefenamic acid. Mefenamic acid is approved for use for fever in only 4 or 5 nations like Pakistan, India, Nepal. We are not inferior to the rest of the world. There is nobody in the US or UK or Europe using mefenamic acid. Combinations of paracetamol and ibuprofen are rampant. Mefenamic acid and paracetamol are rampant. Please do not use these. Combinations are very, very dangerous, can cause serious hypothermia and much more problems. Shock. Febrile seizures are extremely common. All babies below 5 years have at least 4% of all of them have at least one febrile seizure. If there is atypical febrile seizures, when there is a history of recurrent ones, a very bad family history, a seizure which lasts more than 10 minutes, and if there is a CNS origin. But none of these, if they are not there, and if there's good recovery within 1 hour, 1.5 hours, 2 hours, and the age is appropriate, should not be needing more than sponging, paracetamol, ibuprofen in the required doses, and then prevent the next such episode by bringing down the fever early. It's the velocity of the rise of fever which is important, not the degree of fever. Dengue, let's go to specific instances now, because just now we do see a lot of dengue, quite a few. Most dengue is like any other viral fever, except, and it has a very exotic name, very common post-monsoon, almost always in children, self-resolving. Dengue, hemorrhagic fever, and shock syndrome are not so common in children. They are vector-borne, that is the mosquito-borne, and there is a 4 to 10 day incubation. A child with rash, high fever, a headache that the child says it is behind the eyes is very important clue. And there are some cervical lymph nodes like jugulodigastric, which are not very big like tonsillitis, but they are important and maybe the only clue to the dengue, and usually resolves unless there is what is known as saddleback fever. So the child becomes all right and 3 days, 4 days later comes back with fever. And there is a severe leukopenia or a very low platelet count. There you have to be careful. If there are bleeding from sites of trauma, venipuncture sites, abdominal pain which is severe, relentless, platelets which are very low, some low platelets are okay, a hematocrit which has increased especially by 15-20%, and remember SGOT, SGPT is very regularly done nowadays, LFT, and if they are high, reasonably high, that is a danger sign, and these are the children of dengue to watch. Not necessarily admit, but at least watch and good follow-up. Here's an example of a child who was seen on, say, 9th, 12th, 16th, and 17th. So you have a hemoglobin of 11 on day 1, and on 12th, that is 3 days, it's 13.3. In 4 to 5 days, it is 13.9. And that is a very high hematocrit, which along with it you can see. So the RBC also simultaneously goes up. Now, this causes sluggishness of circulation, dengue, shock syndrome. Platelets have come down, and the WBCs. If you see the last column, the 17th October column, there you see that the hemoglobin has now come back almost to normal. RBCs are back to normal. PCV is coming back to normal. The WBCs are raised, but the platelets are not so much, But even in this third slide, the WBCs are high. WBCs rise faster than platelets. But if the WBCs are rising, the platelets are sure to follow. I have never yet had to give any child blood or platelet transfusion in dengue as yet. The rule is that you do that only if the child's platelets are below 20,000, and it is more a medico-legal thing. Unless there is bleeding, really, we don't give platelets. And whatever platelets you give last only a few hours. You keep on doing it. Hospitalization would be in excessive vomiting, poor oral intake, hemorrhagic phenomenon, the biphasic fever that I talked about, severe abdominal pain, an abnormal ultrasound, breathing issues, a very drastic fast rise in PCV or a drop in platelets, extremely high liver enzyme. Prothrombin time, if it is involved, please hospitalize the child. It is the most sensitive sign of liver damage. Malaria, again, we are seeing now quite a few. Fever with chills, rigors, normal periods in between, splenomegaly. Presumptive treatment in Bombay city has no role. The malarial antigen is taken care of. very high sensitivity as well as specificity. Vivax should be treated by the standard chloroquine regime, followed by, after a G6PD test, primaquine for radical cure. The falciparum artemether lumefantrine combination, not so effective nowadays. The Cinerium complex, arterolane and piperacquine, works beautifully in the first or second dose with less side effects. Primaquine is given 1 or maybe 2 doses even in falciparum to stop the spread. It doesn't do any radical treatment, is not needed, but it stops other members of the family bitten by the same mosquito from getting it. Enteric fever, typhoid, again, we've seen 3, I've seen 3 this week. 3 to 16 years, it usually, fever pattern is very erratic, very high. There are no fever-free periods. Splenohepatomegaly, the spleen is usually more enlarged. A tumid abdomen, like a distended kind of abdomen. Vidal has been mentioned to be condemned. Please do not use the Vidal. The Vidal, you have to do 2 tests. One on the 10th day of fever, one on the 20th day of fever, show a doubling of titers. So by then the child is either in the ICU or better already. A very important clue in a CBC, if you find a 0 eosinophil, just keep your antenna up. Blood culture is the sine qua non. That is the bacteric culture, is the most important investigation. Rapid tests again take 7-10 days. Please, IgMW, whatever, is useless. The drug of choice nowadays is azithromycin, which is the first drug, and cefixime, second. No other drug usually is needed. We used to give more ceftriaxone IV if your child is not able to eat, drink. Maybe that is a possibility. Combinations of both azithromycin, cefixime, and so on should not be, please, not be used. Respiratory infection is almost every child has one. Throat, tonsil, sinus, ear. Please do not use cefixime, Ziffy, Fix. These drugs, cefixime, is only good for UTIs and GI infections. Has absolutely no role in a throat and chest, and wrong. First generation cephalosporins are fine. If it is really bad, amoxiclav combination is fine. Azithromycin is okay. Please do not use these combinations. I have shown you these pictures. This is a paracetamol mefenamic combination. This is a cefixime ofloxacin. Ofloxacin has no role. There used to be this original Cifran as the first drug in typhoid. If the nalidixic acid is resistant in blood culture, even if it shows sensitive to oflox, it is resistant. So please do not use this combination. These are real pictures in my clinic. And Pheronix, it sounds like an iron syrup. It is a meropenem, for God's sake. Any child who needs a meropenem should be in the super ICU in a brilliant pediatric hospital. Nobody should get oral meropenems. Ferropenem, sodium, I don't even know these names. A low respiratory infection, bronchitis, is very common. Pneumonia, pickup is very important. So the pickup of pneumonia is if a child doesn't have too much fever and is tachypnic and is not wheezing, almost always look for a chest X-ray is a very important investigation. And chest signs, of course, if you see bronchial breathing, pain in the chest also is very important. The CBC findings, if you know there are high counts, please do that. We have an H1N1 flu nowadays. It's nothing. People will give oseltamivir, but the oseltamivir is only given and it's useful in the first 1 or 2 days. If you start later on, it doesn't do anything. Yes, oseltamivir will stop the spread to other members. That may be a condition, but doesn't help the child. Please do not use aspirin in children anyway, especially in flu, leads to Rey syndrome quite every once in a while. Viral infections, by far the most common. Measles, mumps, rubella are much less now because of the vaccination. Roseola infantum, Mandar covered, and this Nehal too. Chikungunya again is mentioned. It doesn't do much to children except pain. Kawasaki is important if the fever is really prolonged. C-reactive protein is extremely high. Platelets are persistently high. Please, please, please think of Kawasaki and other rheumatic conditions. But again, this is the time then to refer the child. CBC, there's a usual investigations which should be more than enough. A malarial antigen, not parasite, a dengue NS1, a routine urine, very important, a chest X-ray, a CRP, SGPT, SGOT, then if required, blood culture, BACTEC aerobic, a urine culture if required on the urine routine is the abnormal, and an ultrasound for a hidden abscess somewhere, liver abscess or some abscess sitting somewhere, or a collection of pus. COVID-19 just now there is COVID again. It's all, I don't think there's a much problem in children. Cough may or may not be present, high index of suspicion, and contact history is usually how you diagnose. Shortness of breath, these are very common symptoms, pharyngeal edema, diarrhea, vomiting, myalgia. I mean, nothing specific for COVID-19 itself per se. A lymphopenia, a rise in the liver enzymes, a very high CPK, myoglobin, that is myositis, a CRP-ESR, high procalcitonin, and a high D-dimer. Again, D-dimer is not something that we should do all the time. And this is again a hospital investigation once a child is admitted. But it is mentioned here. Imaging, when there are ground glass opacities, chest X-ray and the consolidation, interstitial anomalies on CT, and a consolidation with a halo sign, a brightness around. Usually, sometimes they used to say, but it's a very subjective kind of report. Supportive care, oxygen therapy, remdesivir and all that is now not given. No more. Thank you. If there are any questions, they are absolutely welcome. Chat.
Sir, there's one question. Can you please explain the volume of fever versus degree?
Pardon me? Volume of fever.
Volume of fever versus degree.
So volume of fever, especially in febrile convulsions, you may get a febrile convulsion at 101 fever and not get a febrile convulsion at 105 fever. The importance is the velocity. If the fever was not there at 5 a.m. and the fever is 102 at 5:20, you will get a seizure. If you go to 105 in 5 hours, you will not get a seizure. So most important is to bring down the velocity. So the most common thing and the best thing to do is use tap water, bring the child's fever down with sponging, make the child naked, not just on the forehead or tummy or anything, and that will bring down the temperature within minutes. Secondly, you can alternate 2 drugs for fever in the appropriate doses, like ibuprofen and paracetamol every 4 hours. So 3 o'clock you give ibugesic, 7 o'clock you give paracetamol, and then most of the time this will take care and you can prevent. You see, because giving frisium or clobazam is useless because it takes 8 hours, 10 hours for the protective level to come up. So these are again mentioned to be condemned, not to be used. It's like, bolting the stable after the horse has run away. Or the seizure aa hi jayega. That's not important. I think that's what I hope I have answered your questions.
Sir, Dr. Suhas Gosavi, sir, if you could just elaborate your question further. You've written in the chat box UTI used for URTI. Dr. Gosavi? Paresh Desai, sir, if you could...
UTI, I don't know what this means.
I think
something
sir,
in my presentation, but I mean, they are completely different things. And UTI, what I said was about UTI was that UTI in the first few months of is, it is a hidden, you don't see it. So you have to keep your cantina up and a urine routine should be enough. Sometimes collection of the urine is a problem, but there are very nice neonatal sticking kind of bags which you can stick around the genital or the urethra and you can collect the urine. It doesn't take time. It takes 10 minutes to get a report. If it is positive, then if there is a very high pus count, then you send a culture. URTI, you don't need to do anything. And male UTIs are if you are proved UTI, a sonography, MCU may be needed and should be done. Typhoid fever, yes, azithromycin is first line nowadays because typhoid germ is intracellular. Azithromycin, concentrates itself very well in the intracellular area, and therefore the relapse rate. I want to tell you that in enteric fever, if you treat just with one drug like cefixime or ceftriaxone, there are 25 to 30% relapse rates. But if you use azithromycin simultaneously, it has come down quite a bit. You don't see too many relapses now. So azithromycin, yes, is now the first line. 20 per kg, yes. And the days should be at least 6. Any other questions, please?
Any other questions? You all can also unmute yourself and ask the question directly to sir in case you've not typed it or anything of
You
that
can
sort.
just unmute yourself and ask. Yes.
Can I ask a question?
Yes.
Yes, sir, please.
Sir, dose of amoxiclav in entry.
So amoxiclav is again should not be used in entry. But amoxicillin plain used to be used. Clavulinate has no role in entry.
Any chance of using chloramphenicol in a resistant case?
Chloramphenicol, sir, is first of all, you will find it very difficult to access and get chloramphenicol. Secondly, it has a very technical, side effect of severe bone marrow suppression. If there are much safer drugs, why should you use this thing? And chloramphenicol, they are not even doing sensitivities anymore in labs because we don't want people to use it.
What's about Septran IV now available also?
No, available though, sir, there will be many things, but again, sulfa drug, why would you want to put your child that 1.001% risk also, why do you want? When there are risk-free medicines. Yes, Dr. Jayadil, anything else?
Sir, there is one question in the chat box by Dr. Abhishek Singh.
Yeah.
If phenytoin can be used for febrile seizure and if seizure
So
is not
phenytoin, so if there is an acute, you see a child with a febrile seizure, you can give IV diazepam, IV midazolam, and there are midazolam sprays now in the nose which act as fast as an injection and doesn't need an IV line to be put. Phenytoin is not a drug for febrile seizures anyway. For people who have recurrent febrile seizures and you want to put on a prophylaxis, the drug would not be that, it would be valparin sodium. Not phenytoin. Again, too many side effects. In a girl, too many masculinizing and all kinds of problems.
Sir, syrup for malaria in children.
Okay, syrup for malaria, the two drugs available are Nivaquine and Clariago. So, jitna kilo hai, if there's a 15 kilo child, you give 15 ml single dose first, 6 hours later 7.5 ml, 24 hours after first dose 7.5, 48 hours after the first dose 7.5. Nivaquine, same, it's just a brand difference. These are the two brands available. There are tablets also.
Thank you, sir. So I think there are
Dose of
these are the
syrup
questions.
combiflam. I just said, please do not use combiflam. Use ibuprofen and paracetamol separately. Nowhere in the world is this combination available. In America, England, Europe, Germany, please do not use. Dr. Tulin, no combiflam.
Thank you, sir. Sir,
Dr.
Dr.
Suhas,
Suhas.
maybe, and no, I have not, maybe made some mistake. But anyway, now I have clarified.
Thank you, sir. Thank you, Paresh Desai, sir. Our next
you.
speaker is Dr. Amin Kaba, sir. If there are any further questions for Dr. Paresh Desai, you can still put it on the chat box. Sir will take them later. Till then, we'll go to the next speaker. Our next speaker is Dr. Amin Kaba. He's a consultant in pediatrics at SRCC Children's Hospital. His topic would be gastroenteritis in children.
Good evening, everybody. We're just setting up the presentation. You can have a small
Sir, welcome,
toilet
sir.
break, or maybe even someone can grab a cup of tea or something. We have still about 100 people. That's good. 98. Good evening, everybody. After a wonderful 3 presentations that we've had, I think I'm coming to the most hot topic of the season. Gastroenteritis. It's the monsoon season. We will be taking so many patients on this, and it's important that we know what is the right approach and what is the right treatment that is recommended. I must tell you something that my talk is entirely based on the standard treatment guidelines issued by the Indian Academy of Pediatrics, and also heavily on the grid module, which is also another module on management of diarrhea and dysentery in children. So let's come to it directly. Acute watery diarrhea is defined as a change in the consistency of stool, leading to loose or liquid stools, and or an increase in the frequency of evacuations to 3 or more in 24 hours, with or without fever or vomiting, and lasting for 7 days or less. Please, it is important to ask the parents how many times the motion, it could be just one motion which you can completely ignore, or whether it's 10 motions. Please remember that viruses are the most common agents which account for more than 60% of the cases in our day-to-day practice, followed by bacteria and followed by parasites. And globally, rotaviral infection still remains the leading cause of diarrhea in children less than 5 years of age. A persistent diarrhea or a chronic diarrhea is something that goes on for more than 14 days. What are the common causes of diarrhea? So viruses like rotavirus, novavirus, adenovirus, please remember, okay, we associate adenovirus with usually an upper respiratory tract infection, but even they can cause diarrhea. Bacteria, common ones being E. coli, Shigella, Salmonella, and of course sometimes Vibrio cholerae and Campylobacter as well. And parasites are commonest ones being Giardia and Entamoeba. In immunosuppressed patients, we have Cryptosporidium and Isospora. Rotavirus, again, more than 40% of all hospital admissions worldwide are because of rotavirus. However, the proportion of hospitalization has gone down tremendously because we have been vaccinating the children now. Even the government of India is offering rotaviral vaccine to all children. So the decline is massive even in India now. Remember that most of them will be viral and not bacterial. Most of your bacterial will come with high fever. They'll have tenesmus. They'll have a toxic look on the child. Frank blood would be present. There would be severe abdominal pain and sometimes even convulsion in a shigellosis. The viral origin usually may have a dual symptoms, something like an upper respiratory tract infection, upper respiratory tract symptoms as well as vomiting. and you will have a common similar illness in the family as well. Remember, CBC, CRP, procalcitonin, none of them have any kind of significance in confirming whether it's a bacterial diarrhea or a viral diarrhea. So we must importantly find out that whether the patient has no dehydration, some dehydration, or severe dehydration. Severe dehydration, even family member can pick it up. You have sunken eyes, not able to drink water, the skin pinch, which is a classical thing all of us have learned during our graduation days, goes back very slowly. Some dehydration is where the patient needs to be really taken care of so that doesn't land up with severe dehydration. You have a restless child, you have an irritable child, and really wants to drink water. And no dehydration, obviously the child is not dehydrated. This is the line which I want everyone to take back home. Children with acute watery diarrhea do not require any diagnostic workup or antibiotics. This is the most important message which everyone should take back home tonight from here. So remember everything, origin, duration, progress. You need to take the history first. You have to know the duration of diarrhea and the number of watery stools per day, whether there is presence of blood in the stools or not, presence of vomiting, fever, cough, a recent illness in the family or in the child, pre-illness feeding, but the child was never eating properly, and you say the bacha kha nahi raha hai. So you should know how the child was eating. Bottle feeding is extremely important. Need to take that history because bottle, as we say in India, it should be sold actually with a death certificate. You cannot maintain the level of hygiene in India and you'll end up in more trouble. Any kind of fluids that have been administered to the child, food, drugs. Many a times it so happens that the parents have been feeding the child only juices and the child is on a high sugar diet, which causes loose motions. Child is only having water, obviously we pull up, throwing out only water. Also, many a times it happens, especially in medicos, that they have not constituted the ORS properly and the child lands up with hypernatremic dehydration. Immunization. As recently as 2 days ago, I had a child living in Bombay, good family, and the child has not been given a rotaviral vaccine. HIV status if known, and any kind of comorbid conditions. Importantly, see the general condition of the child, check for signs of dehydration, check the nutritional status of the child. This is important because that will also help you in deciding whether you need to give antibiotics or not. Most important question, whether the child's stool contains blood, and obviously a general and systemic examination. An important question to ask the parents also would be whether the child is passing urine or not. Even if the child passes 10 motions, or if the child is drinking water properly, having ORS properly, should be passing urine continuously. If the child has not passed urine for more than 6 to 8 hours, that's almost an indication for admitting the child. What do we use for resuscitation? This is ORS. In most of the cases, whenever the child comes to you and whenever the child can drink, it has to be ORS, ORS, and ORS. Remember, when giving IV lines, plain dextrose should not be used as electrolytes are not given in that, and the child will end up with severe electrolytes and will end up in more trouble. Normal saline or ringer lactate can be used in almost all patients for resuscitation. A very important part, microbial diagnosis in GIT infections. Remember, most of the times, no investigations are needed, neither a stool routine or stool culture, never ever in routine practice. Stool culture will often grow E. coli, and there is absolutely no role for any antibiotics in that, or kind of any lactose restriction or something. When do we need stool culture? Only if the child is immunocompromised, you're looking at a septic child, it's a chronic protracted diarrhea. If it's a chronic protracted diarrhea, you and I are not going to treat it. You'll be sending it to a pediatric gastroenterologist, or you're doing it for a research or epidemiological purposes. As I said again, children with underlying chronic conditions, someone who is on cancer treatment, someone who has an inflammatory bowel disease, the symptoms have gone more than 7 days. There's an outbreak in a school or in a hospital or a hostel. Children with very high grade fever or at history of travel to at-risk areas. History of travel is more important for patients who are in the Western world and all. For us, we are in India. We know that how fantastic our water supply is. When a child comes with severe dehydration, you have to investigate the patient. You have to look at the renal function test because you don't want the kidney shutting down and be hit with uh, renal failure suddenly, a pre-renal failure or a renal failure. We need to look at serum electrolytes because the child may be in hyponatremic or hypernatremic dehydration. You need to look at the potassium levels because the child may be hypokalemic. You might land up with a cardiac arrest sometimes. And obviously, a sugar needs to be done. A very important cause, a patient can come with dehydration if the patient first time presents in diabetic ketoacidosis. You will be shocked. It has happened so many times that the patient is being treated for 3 days. The sugar has not been checked and the child doesn't become conscious. They're doing a lumbar puncture to rule out a meningitis and suddenly find out that the sugar is 500. Please throw this test out of your clinics. So this is the most important chart. We have been taught this day in and day out. I will again try to go through this chart with you all again. It's always plan A, plan B, plan C. No dehydration, some dehydration and severe dehydration. The percentage of body weight loss is 5%, 5 to 10% and more than 10%. And the fluid loss, look at that. It's when you're looking at no dehydration, still less than 50 ml per kilo. Remember, just as a ballpark figure, it's 100 ml per kilo is the normal intake you require. So when you're looking at plan B, you're almost looking at half the body weight, half the fluid has gone out already. When you're looking at plan C, it's a very, very urgent replacement of the fluid deficit and the electrolyte deficit that we need to give, and that has to be admitted. Even plan B patients should be near a health facility or should be under a very strict monitoring situation. Plan A can be managed at home all the time. Yeah. So how much fluid to give? When you're talking about no dehydration, for every loose stool, make sure the child has little bit of water, little bit of ORS every time. When you're looking at plan B, it's a very, very standardized formula that is there, 75 ml per kilo. You have a 10 kilo child, so 750 ml of ORS needs to go in orally or through the tube, however you can give it. And every hour you assess and shift the child to either to plan A or plan C. Plan C is very important. All of us should know it because if you're hit with a child who has come in severe dehydration and you have the unfortunate part to be around at that time, remember infants you correct it a little slowly over 6 hours, and when it's more than 1 year, it's over 3 hours, and then it's like 30% of it goes in the first 1/6 part. So 30 ml per kg in the first hour and half an hour for over 1 year and 70 ml per kg over 2.5 hours. Nutrition. This is something which people tend to forget when we are treating gastroenteritis. Younger than 6 months, please continue breastfeeding. And for non-breastfed, do not try to dilute or modify the formula. Regular oral feeding is to be reintroduced no later than 4 to 6 hours of rehydration. Once the child starts taking orally, the child will start feeling hungry and start feeling thirsty as well, and you start the oral feeds as well. Children with acute malnutrition, food is also offered in the dehydration phase. Remember, severe acute malnutrition is a dangerous case to take on in your clinical OPD practice. It's always better that the child is in-house, admitted somewhere. Home-based fluids like standard, what we've always been taught, kanji, dal water, rice water, soups, salted lassi, lemon drink, coconut water, less sugar always. Remember, no sugary drinks. Plain water also can be given if the child is not willing to take this. Elimination diet is not indicated. And always remember an extra meal a day with energy-rich foods for at least a week or two after the diarrhea stops so that the child can get back to his or her original weight. What can be given? As we said earlier, home available fluids such as rice or pulse-based drinks like rice water and dal water, vegetable soup, salted lassi, lemon drink, coconut water, and even plain water. What not to give, never to be given. All your commercial carbonated beverages like your colas, commercial fruit juices, all of them are very high in sugar content, will actually increase the diarrhea. Sweetened tea or coffee, energy drinks, a strict no-no. Well, you used to always say घर का बना हुआ ORS दो, but the problem is if it's not prepared correctly, it is not going to correct the electrolyte imbalance, and in fact, you'll land up in more trouble. This is the actual recipe how it's to be made. 1 level teaspoon of salt and 8 level teaspoons of sugar in a liter of water. If you don't make it this way, you're not doing it correctly, and still your teaspoon may not be standardized, so it's always a headache. When to use antibiotics? Children less than 3 months. Remember, you're not going to be doing this in OPD practice. Any child with underlying chronic conditions or immunodeficiency, children with severe acute malnutrition, and infections with Shigella, ETEC, Vibrio cholerae, and Yersinia. All these, ideally, make sure that a specialist also is in the loop. Otherwise, you can land up in trouble. And any kind of invasive bacterial infection like sepsis, the antibiotics to be used. Take a screenshot of this. Remember, if you're looking at dysentery is blood with stool. Ceftriaxone, a sick child, 50 to 75 milligram per kilo in 2 divided doses for 5 days. Cefixime, 8 to 10 milligram per kg, divided in 2 doses for 3 to 5 days. Quinolones, lot of resistance because of lot of misuse of the fluoroquinolones in routine day-to-day practice. So lot of resistance, they are not used. Anyways, in children less than 8 years, we are afraid of cartilage damage. So we avoided that time as well. Look at cholera. Cholera, it's a single dose of doxycycline. All right. Or a single dose of azithromycin. Campylobacter, how many of us have actually used azithromycin to treat a diarrhea? Almost never. An immune deficiency only and only then. For cryptosporidium, when you proved it, you'll be using nitazoxanide. Very important. No furazolidine, no amikacin, no cholesterol, and no standard combination that is so widely available. 30 years of practice, and I have yet to use even one single prescription on my pad ever. Amikacin is not recommended for diarrhea in any kind of guidelines or literature. Amikacin has the biggest problem of causing a very bad Clostridium difficile secondary superinfection if you use it for diarrhea, and you'll land up in big trouble, and as late as even 2 months after you having used it. Cholesterol, oral cholesterol, so commonly used for small children in diarrhea. Please do not use it. Cholesterol is one of the only big guns left now, used for severe infections in the ICU setting. I myself have used it thrice in the last 20 years only. Oral cholesterol acts as only a local antibiotic against only Shigella. It is criminal, a crime to use such a medicine for oral drugs in for a simple, probably a viral diarrhea. Metronidazole plus any of your quinolones, completely irrational combination. One is to be given thrice a day, one is to be given twice a day. You are either dosing, underdosing, or overdosing one of them, and you will still land up in a lot of trouble. These are the standard guidelines by even the WHO. They are unusual cause of bloody diarrhea in young children and less than 3% of the episodes. And you use it only when you actually demonstrated trophocytes of E. histolytica containing red cells. So a child with dysentery should not be treated routinely with metronidazole for amoebiasis. These are the doses that are there. For giardiasis is metronidazole 5 milligram per kg per dose every 8 hours for 5 days, and for entamoeba 10 milligram per kg 8 hourly for 7 to 10 days. There are so many kids who don't require it. People say anecdotally that yes, I have given and the patient responded, but 99% of the times they don't require it. And the people who actually require it, they are given for 2-3 days. I've had so many patients who come and tell me, हमारे पास घर में रहता है, the standard name, I'll not take the name, कभी भी मोशन हुआ तो हम 1-2 चम्मच पिला देते हैं. And coincidentally, such a patient landed up with me once, and 3 members in the family had landed up with an amoebic liver abscess. They were admitted, all 3 of them, and they were in the hospital for almost 3 weeks. Probiotics. We just love writing these. They are effective in reducing the duration and intensity of symptoms, but not very much. And only 3 are standard recommendations. So your Lactobacillus rhamnosus GG, your Saccharomyces boulardii, and now even L-reuteri. And remember, these are adjunct. They are not the mainstay of therapy, and the dose that is there.
Lactobacillus more than 10 raised to 10 CFU per day for 5 to 7 days. The evidence is low to moderate level. Saccharomyces boulardii used to be used a lot, but now the evidence is very low to low level evidence in acute diarrhea. It's 250 to 750 milligrams per day for 5 to 7 days. And any kind of probiotics in the therapy of acute dysentery and persistent diarrhea is not recommended. Clostridium difficile, some role may be there for prevention in high risk groups as well. Zinc, very, very important, helps in reduction of the duration and the severity. And it also prevents further episodes of diarrhea for next 3 months because it actually builds up the gut motility. Less than 6 months to 5 years, it's 20 milligram per day for 14 days. And between 2 to 6 months of age, it's 10 milligram per day. All your syrups are usually 20 milligram per 5 ml. So less than 6 months, it's 2.5 ml once a day for 2 weeks. And more than that, it's 2.5 ml twice a day for 2 weeks. Anti-emetics, yes, ondansetron works. Standard recommendation 0.15 milligram per kilo per dose, and it helps in reducing vomiting. Since we have time, let's go through the cases. You all can write down in the chat box what is your impression. A 9-month-old boy, exclusively breastfed, came with acute onset of fever on 101 and had loose watery stools without any blood, 15 to 20 per day, some dehydration, stool shows 40 per cells, some occasional RBCs, hemoglobin, CBC is nearly normal, CRP is 21. Do you need to do any tests in this child? Anybody can write in the chat box. Oh, the answer came up. So this is an enterotoxigenic E. coli, rotavirus, no test needed, no medicines needed. Second, this I think everybody should get it. A 9-year-old female was in a pilgrimage center and was brought in hypotensive shock. And how would you manage this child? Obviously, hypotensive shock, we need to first stabilize with IV boluses, take care of airway breathing circulation and the sugar. Stool for hanging drop, not everybody can know it. And it's if you're able to do it, nothing like it. However, darting motility may not be picked up. And obviously, this child was a case of cholera. Third child, 2-year-old boy, case of acute lymphoblastic leukemia, was on maintenance chemotherapy, was brought with fever and loose stools, persistent diarrhea, underweight, toxic, child had moderate dehydration, systemic examination was normal, dehydration was corrected, stool, everything was sent, cultures were sent. This child had a hemoglobin of 8, count of just 1200. Total neutrophils count was less than 300. Platelets were just 25,000. This child turned out to be a cryptosporidium diarrhea. Was started on nitazoxanide and azithromycin, and the child went home. So, what are the key messages that we have? Viruses remain as the predominant cause. The degree of dehydration needs to be ascertained every time in the initial assessment. That's what will help you in deciding the further course of treatment. In most cases, you do not require any kind of diagnostic workup unless the child is sick. Low osmolarity ORS, that's the only ORS available. I'd like to take 2 names, even publicly, Enerzal and ORS-L. These are wrong. These are not to be used. They are both sugar drinks. They very, very categorically say on the packet that they are not ORS, but the name is such that people mistake Enerzal and ORS-L as ORS, and people use it and land up with more trouble. Ringalactate is the preferred fluid in all age groups for the initial treatment of severe diarrhea. Zinc supplementation is efficacious, safe, and recommended. Antibiotics to be used only when indicated. We went through the indications a couple of times already. And probiotics can be used only and only as an adjuvant treatment. Thank you for a patient audience, and I can take questions if there are any.
Thank you, Kaba sir. We have some questions, and I think one of the questions, if Paresh Desai sir is still there, the first question, if we go in sequence, it's for sir, I think.
Yeah, go on.
Sir, someone's asked, Dr. Divya actually has asked that the available combinations of paracetamol and ibuprofen,
you are advising to use even paracetamol and ibuprofen as separate medicines?
Yeah, so absolutely use separately. I'll just give you a little analogy. I mean, if I have to push one person, I don't need a truck to do it. I can do it with my hands, or two people, or a scooter can push. So please don't use a truck. Use separately. And the dose of paracetamol is, if you're going to give, it's about 10 to 15 per kg, and ibuprofen is almost always 10 per kg. All ibuprofen preparations in the world are 100 milligrams per 5 ml. Paracetamol can be drops, which is 100 milligram per ml, syrup, which is 120 or 250 per ml. The 500 per 5 ml should not be used because its overdose is very common. So you use them separately and use them at 4-hourly intervals. Give ibuprofen at 4, give paracetamol at 8, then 12 again ibuprofen, and that should normally take care of this. Please do not use combinations. I promise you, I have never used Ibugesic Plus or Combiflam or Flexon syrup ever.
Thank you, sir. Sir, Dr. Kaba, I think then the following questions are for you.
Yeah.
If you can access the chat box, or I
I'm
will
looking
read
at them. Yeah.
them.
So when someone's asked about features of amoebiasis in children, so forget the amoebiasis because the germ does not study the books. If you get amoebiasis in your stool routine, you have frank blood, you sent a stool routine, and you get that in your stool routine, only then use metronidazole, otherwise not to be used. Someone has also asked volomycin, aldiamycin. I don't even know what is aldiamycin. Volomycin, never ever used, never ever recommended. Please throw it out of the window. Please stop prescribing it. So the company also stops making it. Someone has had Econom type sachet or syrup azithromycin. So azithromycin, Campylobacter, you cannot actually judge always clinically because Campylobacter may not come up so easily. Clinically, you may not be able to suspect it so well. But if you have been religious enough for 7 days and not given any kind of antibiotic, you may give one dose. You may try with an azithromycin. And which drug is to be used? Econom type sachets. I don't understand that. Dr. Tulin, can you just elaborate? What have you asked? Econom type sachets. And Dr. Ishwari has also asked, can we use metadoxin for gastroenteritis? Gastroenteritis is hyperammonemia. What is metadoxin? Please tell me. Probiotics, as we said, they are adjuvant treatment only. They may or may not work. It's just at the base, low to moderate level, it will help your child. It's a really expensive treatment, 40, 50, 60 bucks a sachet. Your patient needs something as a placebo. You want them to get off your back, please use it. Zinc is more important. One more thing, I may not do a stool routine in the child, but a child less than 1 year, especially a girl, please do a urine routine. You can miss a UTI and give antibiotic, and the child will end up with a very bad pyelonephritis later on. So if you don't do stool routine, is fine, but never miss out on a urine routine.
Audience members, you all can also unmute yourself and ask questions if any, in case you all can't type or anything. You all can unmute. We have all the speakers who are there online. We can start with the official question answer session right now. Anyone would like to ask any questions to any of the speakers? So we'll just wait for another 3-4 minutes in case if someone has any questions.
Sure.
Yes.
Injection paracetamol is quite a dicey injection, causes a lot of injection swellings and abscesses, and really speaking, no real need. IV paracetamol is used in hospital settings more in the context when a child is not able to post-op, when a child is nil by mouth, and when a child is vomiting non-stop or something like that. But injectable paracetamol intramuscular, absolutely not. Should not be actually available. They are oily preparations.
Any other questions from the audience? Sir, I think we can end the discussion. Sir, if you want to add anything more, Dr. Desai, Amin, Kaba, sir.
I think I'm speaking too much now.
No, sir. Thank you so much, everyone. Dr. Mandar, Bapaye, sir, Dr. Nehal Shah, Dr. Paresh Desai, and Dr. Amin Kaba, sir. Thank you so much for the wonderful presentation and the talks. Thank you so much. Thank you to the audience as well. Thank you so much.
Thank you.